Good evening, everyone, and welcome to our presentation this evening on digital health tools as a game changer. And they certainly are. I think there's mounting evidence that technology and digital health tools are really transforming how healthcare is delivered across our country. And tonight we'll be hearing some real-world examples of how these digital health tools are being used and utilised across various parts of our country. To start, I'd like to introduce myself. My name is Kathy Rainbird and I'm a Senior Provider Adoption Lead at the Australian Digital Health Agency. This webinar is actually a collaboration between the agency and the Aboriginal Health Council of Western Australia, and we're being joined by Dr. Marianne Wood from there, and from the WA Primary Health Alliance, and we have Simon Benj, who's the Digital Health Lead there. So thanks for joining me, everyone, and we will start by acknowledging the traditional owners of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to them and their cultures and to elders both past and present. We're joining you from all parts of and all nations, or just about as many nations as we possibly could be tonight, just about. I'm speaking to you from Menang Noongar country, and I'd particularly like to extend my respect to them and their elders, as well as welcoming any Aboriginal or Torres Strait Islander people who are joining us for the session this evening. Good to have you along. Just a little bit of housekeeping to start with. This session is being recorded, so if you don't manage to attend for the whole session or you miss it, you will be able to catch up on the video later on. So as a result, your microphone. So I'm really excited about our webinar this evening because we have some fabulous panel members, and I'll get Marianne to introduce everyone in a moment. But we're really wanting to celebrate what's been achieved and how digital health tools are really delivering real benefits at the coalface of the healthcare system. So our panel members will be sharing their insights and their experiences, talking about how they're utilising their digital health tools in their different settings and how it's been a game changer for them and their team, as well as the people whose communities they service. We'll talk about the benefits and, of course, the challenges of using these different tools and share insights. So after each of the three presentations or discussions, we'll then have time for a panel discussion. So Marianne, I'd like to call on you now, please, to do some introductions of our special guest panelists, please.
Thank you, Kathy, and hello, everybody. I'm joining you from Wajak Noongar Butcha in Perth. So our first speaker today is Associate Professor Jill Benson, who has been a GP for 40 years and wears, as you will learn, a number of hats. For the past 20 years, she's been mostly working in remote Aboriginal communities in the Western Desert, currently Chunchunjara, you can look that one up, with refugees in Adelaide, with Doctors Health South Australia, as a medical educator and as a researcher for the GP training organisation in South Australia and with the Australian Medical Council. She's also doing volunteer work with Rocket Ship in Tonga as a medical educator, also done by remote, obviously, and sits on their board. She has presented and published nationally and internationally about medical education, refugee health, doctors' health, and mental health, and she was awarded an Order of Australia in 2012 for her work with Aboriginal people, refugees, and in mental health. Jill is literally all over the place, and tonight she's dialing in from Norfolk Island. Our second speaker is Dr. Toby McClay. Toby is another GP with an exceptional service to remote communities across Australia for many decades. For the past 20 years, he has worked in the far corner of WA Goldfields at Nungaluwili Aboriginal Health Service in Wiluna, where he has been an absolute staunch advocate of digital health and was, I'd say, a very, very early adopter of the My Health Record. I challenge anyone actually to have had more patients signed up for the My Health Record than Toby has, long before we even had opt-out. In 2009, Toby was awarded a member of the Order of Australia for service to medicine in rural and remote areas as a practitioner, trainer and mentor through contributions to health services and programs in Indigenous communities. and Toby's dialing in from Adelaide. Our third speaker is Dr. Amanda Stafford. Amanda is an emergency medicine specialist who's been working in Perth only in the City Hospital, the Royal Perth Hospital, for over 20 years. Her particular interest within emergency medicine is the complex ED patient, whether medically or socially, drug-seeking, or just presenting frequently. She develops patient management plans, PMPs, where needed, and manages the ED's PMP register with its 200 to 300 individual plans. The basis of these plans is patient information, and My Health Record is now an important resource, especially given that our hospital is proud to have Perth's highest number of ED presentations by Aboriginal patients from both metro and rural areas. So they are our three panelists from the evening, and Amanda is actually dialing in from Wajak Butcher as well in Perth.
Thank you so much, Marianne. So to kick things off, I guess I just wanted to give a bit of national perspective, and many of you who've attended any of our webinars will be familiar with this slide. It's the basis of the work that the Australian Digital Health Agency is working towards in collaboration with all of these different partner groups, with all states and territories, jurisdictions, clinical peaks, key stakeholder organisations, PHNs and affiliates. So it's a real collaborative approach to deliver these digital health tools at that national level. But often we don't hear what's happening on the ground and how that delivery of these tools then is really bringing real benefits directly to people in their healthcare. So I think tonight is a real highlight and a celebration of those benefits that we can see coming to fruition, which is fantastic. So the key tools that I guess we'd just like to perhaps highlight tonight are the ones that many of you will be familiar with that we've been working towards delivering as part of that digital health strategy. My Health Record, of course, being a key component of that. There's also significant work being done and increased utilisation of secure messaging. Telehealth, of course, coming to the fore, in particular in relation to the COVID-19 pandemic and shutting down and locking down of communities as well as cities, and electronic prescriptions, also supporting that work in terms of making prescriptions readily available direct to people's phones rather than having to come into a face-to-face consultation. So I think that's enough from me. I don't need to hog the stage. I'm ready to hand over to our wonderful presenters and panelists. So Jill, I'll call on you to reshare your camera, and I will just jump out of my slide set and jump into yours.
Fingers crossed my internet connection stays. So thank you very much. I come with mainly my Spinifex health service from Jundunjara hat, but I want to briefly talk about the doctor's health service that I work in and talk about the Karkara Health Alliance, which is an alliance of the 3 health services in Yalata, Oak Valley and Jundunjara, which goes across the border. So can I have the next slide, please? So Jundunjara is on Spinifex country, which is why it's called Spinifex Health Service, and that's a picture of some Spinifex. It's a small community with between 100 and 200 people in it. It's about 750 kilometres east of Kalgoorlie, and that's the nearest place. It's probably one of the most remote communities in Australia and probably one of the most remote communities in the world. You can see the airstrip there, which is a lifeline for health services in Jundunjara, because if there's any sort of weather, the roads can be closed. The food comes in from Ceduna in South Australia because the road to Kalgoorlie is often not working very well. Can I have the next slide, please? So the Spinifex people have been living on this land for many tens of thousands of years. So the baby in that photo that's being held is the old lady in the middle. They are very traditional people. They still have a strong cultural connection to the land. They're Ananu people. They are the famous Western Spinifex artists. So one of the artists in Jundunjara recently won the National Aboriginal Arts Awards. And in the 1980s, some people came in from the desert who'd not seen any white people before. Because they're so far away and because they have led a traditional lifestyle, they've stayed healthier over the years. But gradually, Western civilization has moved into Jundunjara and they've developed a lot of the chronic diseases that other Aboriginal people have in other places. Can I have the next slide, please? 12 years ago, I started the Kakarawillara Health Alliance to bring healthcare into Jundunjara from South Australia. Before that, they'd only really had incidental healthcare from the RFDS from Kalgoorlie on an as-needed basis. And they asked, could the service that I was delivering in Yalata be expanded into Oak Valley and Jundunjara? And that seemed like a fantastic idea and has worked very well with a team of people going from Adelaide to Yalata, Oak Valley and Jundunjara for the last 12 years. Well, the last 11 years, because what happened in COVID was that border that we'd all ignored over many, many years suddenly became important. And the border meant that we hadn't been able to fly in. So we had to do something different. Have the next slide, please. One of the things that we know about Aboriginal people is that they have so many vulnerabilities to chronic health issues. So these are just a few graphs from the Australian Institute of Health and Welfare, and you can see that they're looking at the age standardised disability adjusted life years for selected diseases as far as remoteness goes, as far as socioeconomic status, and as far as Indigenous status goes. And I don't know if it's big enough for you to see, but you can see that Aboriginal people who live remote and have low socioeconomic status have the highest risk of cardiovascular disease, of smoking disease, of pretty well anything. So it's chronic diseases that are the things that have really made a very big impact on the health of the Aboriginal people in Jundunjara. Next slide, please. So when we think about what we can do to help the health of the people in Jundunjara, telehealth has actually worked very well. I've done a lot of telehealth. So in the last year and a half, I've done 196 episodes of telehealth. That's 196 patients in a community that's probably mostly only got 150 adults. That's a lot of people. I've had a lot of discussions with the nurses and a lot of non-client contact. So in the end, I'm doing about 2 days a week of work. And I have the next slide, please. So what can I do? So despite my age, I've managed to become quite IT savvy. I have 2 computers. I have a computer with my remote access. I have a computer that has Zoom on it. I have my phone that the nurses send photos of skin. And I have a writing tablet that I write notes on that I then send to me and to the nurse. With that, we see people face to face because I know the people well. I've been going out there a long time. They know me. They still make jokes with me. I saw a patient today, she was in stitches telling me that she needed an operation and why couldn't I do an operation over the computer? I can ask the nurses to do physical examinations, to feel people's backs, listen to lungs, look in throats. We've got a video otoscope, so they sent me an image on my phone from the video otoscope today of somebody's ear. We have a retinal scanner, we do audiometry, ultrasound, ECGs, all sorts of things. I've done joint clinics with cardiologists, renal physicians, endocrinologists, dermatologists, respiratory physicians, and psychiatrists, where I've got the notes and they're talking to the patients. The patients often don't know those specialists, but they know me, and they obviously know the nurses in the clinic. And so that's actually worked really well, having that. And I sort of do the translating of the often quite high-level jargon that the specialists have spoken into the sort of language that the local people can understand, and they really appreciate that, and they can ask questions as well. We have a variety of allied health professionals who are doing everything that they do over telehealth as well. So it's actually worked really well. Can I have the next slide, please? So, as you heard, I'm currently in Norfolk Island, which is one of the reasons my bandwidth's not so fantastic. This is me on my partner's boat on the Murray, and I can also do telehealth from there. This is me in one of the lockdowns in South Australia. It was a very nice place to have a lockdown. So you can see that I've got the two computers there, and that works very well. Next slide, please. So this is the team, and even though it's quite isolating as a doctor doing telehealth, just sitting here, it's amazing working with these people. So this was one of the times when I could actually go to Chunjunjara. I've been out there 3 times in the last 1.5 years. And this is the team I work with. They do the work on the ground. They set up the Zoom meetings. They do all the examinations. I'm not alone. I'm with this amazing team, and that's been one of the absolute beauties of doing this, is really getting to know this team and to rely on them and to learn together how to make this work. We did accreditation as well. We did that all by Zoom, which worked well, which is why we have a disabled parking sign in a place that doesn't have roads. My health record has also been a very useful thing. So everybody in Chunjunjara has everything up on my health record, all their investigations, discharge summaries. It's a very mobile population, so they move across the border into South Australia, but also west and north into other Western Australian communities. And so my health record has been absolutely amazing, because I can look up what medications people are on, what their last hemoglobin A1C was, when did they last have their kidney function tests. If I'm starting somebody on medication, so for instance, the other day I was starting someone on a new diabetes medication, I thought, oh, I wonder what my health record says, and there was a diagnosis of pancreatitis within the last 2 years, which meant I couldn't give that medication. Without that, I might have caused another bout of pancreatitis. Similarly, other people can see that the patient, that they don't know where they are, is in my community. So somebody had a recall in another community and were new to my health record. They looked up my health record, could see that I'd just done an Aboriginal health check on that patient, and rang me and said, she's due for cervical screening. Can you do that, please? And I said, oh, I didn't see that on my health record. She said, oh, no, but I've learnt my lesson. I'm going to put everything on my health record now, because I can see that if you'd been able to see it on there, you might have known. So my health record has been incredibly useful. We've got 2 big funerals in Chunjunjara. I just look at what medications people have. If it's on my health record, I look at what they've got and then just transfer it over to the Chunjunjara medication list, which is just wonderful. Next slide, please. So what do I miss? I miss the people. I really miss the people. This is sitting outside the clinic. I don't miss the dogs, I must say, but I'm not a great fan of dogs, which makes this a very unusual job. But I do miss the people. I miss sitting out under a tree talking about mental health consultations. You can't do that so well. I can do mental health consultations, but normally I'd sit out under a tree, both looking into the distance to do that. When I was there, I did an environmental scan. I went around and looked at all the houses and did an environmental assessment of all the houses to work out what the health risks were. I don't get to go to the arts centre and see the old people. I don't get to go to the women's centre and talk about food and women's things. I don't get to go to the school and hang around with the kids and have them all climb on me while I look in their ears. I don't get to do those things. And they're the things that have kept me going out there for a long time, are those things which I really enjoy. There are other things I can't do. I can't put in an implant on, obviously. I can't do a full neurological examination. I can't palpate things. I can't properly feel an abdomen. So it's not the answer to everything in telehealth, but it's certainly been a really good adjunct, and it's been very helpful for chronic disease in particular. Next slide, please. So I just wanted to put this slide up because I'm a fly-in, fly-out doctor, and I really appreciate those doctors and nurses who work, and other health professionals who work in rural and remote areas all the time. I feel like, and I've been doing this for probably 35 years, that part of my role is to support those people. So I've been working at Doctors Health in South Australia for the last 35 years. So I currently do telehealth to rural and remote doctors in South Australia. And because I know what it's like to work in Aboriginal communities for the Northern Territory as well, this is not just mental health, this is physical health as well. Doctors are better at their physical health, but mental health we're not so good at. We burn out more. And for those people in remote communities who last year were locked down, some of those doctors were really stressed. Rural and remote doctors struggle to get good healthcare because they're the only doctor there. And so having telehealth for those people has been absolutely essential for keeping them safe. Unfortunately, the Medicare rules make that difficult because you have to have seen people face to face, and these are rural and remote people that I haven't mostly seen face to face, so I do go out to rural and remote areas sometimes just so we can continue to see them by telehealth. Often the bandwidth isn't good enough in rural and remote areas to do video consults, and Medicare says that we need to do video consults, and they're not 6 minutes. Consultations are usually long and complex. If a doctor has plucked up enough courage to ask for a consult, it's not going to take 5 minutes. So I think supporting each other is incredibly important. And for those of us who are outside those communities for a lot of the time, supporting the people who are. So thank you very much. I'm happy to answer any questions that you have later. It's been really lovely that you've come.
Thank you so much, Jill. That's wonderful. And what awesome stories to hear about how you've been utilising this in such a remote location. And I think that can certainly inspire anyone who's on the line who's not using telehealth yet. In the metro regions, we've got no excuse. If Jill can do it to Chunjara, I think anyone can do it anywhere. So we'll press on with our next presenter, and I'll just have to chat a few questions to throw your way. But I think the first one I'd like to ask is about what you were just telling us before we started the session today, in that when you started in healthcare, what sort of technology did you have, if any?
Yeah, interesting story. It shows my age, I suppose, but the historical perspective is interesting to look at, because I think a lot of young doctors take a lot of digital technology for granted, and a lot of older people are probably still wary of it. But I started work in a remote AMS in Central Australia back in the late 70s, and the only information resources I had were a couple of old textbooks and a two-way radio. And I spent a whole decade out in the desert there, looking after 1,000 people with only those resources. And even the local hospital refused to produce discharge summaries for some years until I harangued them enough. So having come now 40 years later to work in another AMS, I've been mostly out in the bush in an AMS most of my life. We're now in a big clinic in Wiluna. We've got a very transient population of Aboriginal people. We have a lot of FIFO workers in the area, a lot of miners and other workers. There's probably a couple of thousand. We've got all the tourists that come through in winter. We've got all the prospectors and pastoral workers, and it's a really busy place. And I'm a solo GP when I'm there. I'm ably supported by nurses and a couple of paramedics, but we really depend on the technology these days to keep us connected and keep us going. And
at the beginning, Toby,
yeah.
Sorry to cut you off. Marianne mentioned that you've been one of the stalwarts and the really early adopters of My Health Record. So how has My Health Record been a game changer for you and your practice out at Wiluna and the people you look after out there?
Well, it's been I've been using it, loading summaries and trying to use it for the last 8 or 9 years, or however long it's been going, without any kind of feedback. But the results, the efforts you've put in the last couple of years trying to, well, firstly, to get patients all registered and to get agencies and providers all hooked up and actually using it, it's now becoming increasingly more useful. And I'd say to anybody who's listening that, the best thing you can do is have a look at it, get involved, because the more people that use it, the better it's going to become. And so now for me, the real big bonuses are, we don't have we have a regular clientele. We have a lot of visitors come through, constantly seeing new patients who we don't have any info on. So I can just go straight to My Health Record, open it up, find discharge summaries, pathology results, radiology reports, and if I'm lucky, a really good GP health summary, and I really know where I am with the patient, whether it's an acute, assessment of somebody injured in a mine or unwell from a mine, or whether it's a, itinerant Aboriginal person who's come to town to stay for a while. Getting that information directly off there is a real bonus. Otherwise, we resort to this endless faxing around of requests for authorization for personal information, and ringing labs trying to get all the scattered information together. So having it all on My Health Record is a real game changer, and the more it gets used and the more information gets put there, the better it's going to get, and hopefully the more people are going to rely on it.
And Toby, I think you had some fabulous examples of a couple of instances where you'd looked up someone's My Health Record and found some valuable historical information from pathology reports and so on. Would you like to share those? Yeah,
sure. Just recently, I saw a woman in her 50s who'd moved in to get a new job. She'd come from New South Wales, came into the clinic for something, I can't remember what, but in getting the history, it turned out she'd had acute rectus and bleeding about 3 or 4 months earlier in New South Wales. Everything seemed to have settled down. Said she hadn't had any follow-up. Went to My Health Record, had a look, found histopathology, which suggested at least atypical hyperplasia, which is potentially very significant. She didn't really understand the importance of the follow-up. Her home clinic presumably had she'd been lost to contact. So by finding that, we're able to get her on track and get her to the gynae clinic and get further investigation and treatment sorted. A couple of weeks ago, I saw a guy in his late 40s came in with a particular problem and needed a blood test. While I was at it, I thought, oh, look, while we're doing bloods, is there anything else we can do? Got a brief history, discovered father died at 52 of CA prostate. Have you had a prostate test ever? No. But when we discussed it, did the test, got a result that was in the normal range, but significantly above the median, pretty uppish. And then I looked in My Health Record and found he'd had a similar test that he didn't know he'd had, and we'd forgotten he had. That was done about 10 months earlier, and it had basically doubled inside a year. And given that he's 48 and Dad died at 52, this could well be an aggressive prostate cancer that was about to get away from him. So we were able to kind of get on top of it, get him more closely reviewed and referred to get us sorted. So he was about to leave town and could have drifted around the country for a couple of years and presented with his metastatic disease, and hopefully we've nipped it in the bud, courtesy of finding that result on my health record.
And I think that's a good point for me to mention how the agency, the Digital Health Agency, has been working with a range of public and private labs to get connected and contribute their information up into the system. So more and more of those reports are flowing in. I think the public sector, the percentage of connections is getting higher and higher. So keep an eye out. There is a list on our website that tells you which providers and which labs are connected. But as Toby's mentioned, he's already finding useful reports in there, and there are thousands of path reports I know going up. In particular, I know a significant number from WA Health. Toby, one thing you were talking about what you can find in the system, but I know that you've also been contributing information, and the two key documents that GPs generally upload is a shared health summary or an event summary. What sort of things do you use to determine which of those you're going to upload and when?
Well, look, if it's a regular patient that I know and I've got a complete summary and I know they're going travelling, I routinely upload a summary. More recently, I've decided that all my chronic disease clients are on a list of problems and medications. I'm going to upload it anyway, in case I've started that process, in case they decide to go visiting another town or whatever. I'm reluctant to upload a shared health summary for someone whose history I only partly know, and I tend to invite people to go and see their own GP and ask to have their summary put up for them so that I know better and others will too. If however, I see a patient who's not really got a regular GP who we over a period of time get a significant history together, then even though it might not be totally complete, at least I'll put that up as if it's particularly if it's significant information, I'll put that up as a starting point. The other thing I like to do is put up event summaries of significant clinical information, where particularly with the itinerant people, FIFO workers or people on the move, I like to put up an event summary. If I was going to write a letter to the GP saying you've got to see your GP next week and get whatever it is followed up, I will write an event summary. I will make sure my progress notes are neat and tidy and comprehensive and upload that as an event summary and tell them to ask their doctor to look at my health record. That way I'm promoting the whole thing as well. And in addition, I can actually print out my progress note and give it to them as something to take away in case their GP hasn't quite caught up with the times.
Hopefully they are. But I think that's a really good point that you make, Toby, around the quality of the information going up into the system and making sure that when you are uploading, it is accurate and complete and up to date, especially those shared health summaries, and doing them for those key patients who are your regular patients, I think is really important.
Yes,
I guess the other thing I wanted to point out that, Toby, you mentioned that you haven't been getting a lot of feedback about how people are using the system. That might tie in nicely to our next presenter, who is Amanda, who is actually based in Royal Perth. And I know that we've seen some amazing stats coming out from WA Health, thanks to our local contacts there, in terms of the viewing in Western Australia from the hospital clinicians. In fact, I think I won't be stealing too much thunder by letting you know that they're starting to almost hit 100,000 views a month of my health record. So those documents that you are uploading, Toby, are hitting the other end and are being seen, and I'm sure they're making a huge difference. So good on you for all your great work.
No worries, thank you. Well, I'm an active advocate. I'm telling every doctor and every agency that's not participating to join the party.
Good on you. All right, well, on that note, we might actually throw to Amanda. Amanda, if you could turn your camera on now. Fantastic. And to kick off, I guess the obvious question is, working in the emergency department, What sort of clinical information have you and your colleagues been finding in My Health Record and that you found useful?
The emergency department is a 24/7 service, and that means that most of the time that the emergency department is open is after hours with regard to other services such as general practice. And so the uptake of My Health Record has become the use of My Health Record has become very frequent at Royal Perth Hospital, and it's both for patients who come from elsewhere who we don't have a lot of information about, but is also very useful for patients who actually live in the metro area. So I think we have a very large rural catchment area which extends through it'll probably be about half of the state of WA. So some of the patients obviously will be transferred as an expected patient and expected transfer, but we also have quite a number of patients who turn up unexpectedly. So for example, in the last 12 months, we've seen a lot of patients from Wiluna, and we were starting to wonder a little bit about what was wrong with Wiluna because so many of them were in Perth. But what it's allowed us to do, for example, is to see what the health summary is, what people's medications are, because often people are turning up to the emergency department to obtain medications, but they don't know what their names are. So that's been an absolute game changer, because then if we're seeing the person out of hours or even within hours, we can simply go onto My Health Record, see what medications are, what doses, what dose intervals, health summaries, and it's all very quick and easy. So and that applies both to rural and remote, but also to interstate. So we do have people who come from interstate, might be returning, for example, from overseas, are quarantined, but are not yet in their home state. I think the other things that are important are where people are turning up in emergencies. So, for example, they've been severely injured or very ill, and there's been no thought about getting their medication, a medication list, or bringing their medications in, and that's important for us to know. And again, My Health Record, it's quick, it's easy. Another group of patients that are often problematic are people who are under arrest and are requiring a medical clearance, and quite often because we have the police watch house close to the hospital, and quite often they're not aware of what their medications are, and for their safety we're able to look on My Health Record and see what those medications are, and sometimes actually provide the patient with a list of their own medications so that they can follow up after release from custody. It's allowed us also to know who the patient's GP is. So if we're wanting to get further information and contact the GP, the patient may not know who they are or their name, which might be, for example, a very complicated name. They don't know how to pronounce it, and they're not quite sure what practice they go to. The other group of patients is very important to us, and we're using it a lot, is because of the inner city location of the hospital. We have a lot of people who turn up asking, usually out of hours, asking for medications, and these might be medications of potential abuse. They have potential abuse potential. And we're then able to go onto My Health Record and have a look at what they're already being prescribed, or in fact what they're not being prescribed. The dispensing is up to date, so it will be that day or yesterday, and so we can see exactly what they've got. And that may allow us to say, for example, you were prescribed this medication 3 days ago by a local doctor, and that means that today you should still have another 10 days of medication. So we won't be prescribing it for you because we know that you received a sufficient supply of it. Also allows us to have a look at the pattern of attendance. So are they attending a single GP, or are they attending a lot of GP practices? That is, are they doctor shopping? The other thing is that if patients have no My Health Record, so they have blocked information, that makes it a lot easier for us to say, look, we have no actual idea of what you're normally prescribed. We've got nothing on My Health Record. You've presented after hours. We won't be prescribing you anything. because unless we can get a handle on what they already have, we don't want to be prescribing on top of what the person is supposed to have. It's also been very useful in my work for looking at frequent presenters and getting an idea, for example, on my health record of, are they turning up to a GP regularly? Is that a problem that they're using the emergency department instead of a GP practice? These sort of things, because often for frequent presenters there are unmet needs and the solutions to them are really not in the emergency department, they're in the community. So a good step might be using one of our navigators, our health navigators, to link them to a good GP and for them to get care there. The final use that I would find it very important for is I work half-time with the Royal Perth Homeless team, and we're often trying to find where homeless patients are. And my health record, because it's Australia-wide, will often let us know where a person is, where are they being dispensed. And so we can then find, today I was looking to find somebody that we hadn't seen for a long time and discovered that in fact he'd returned to New South Wales because he had a consultation and a prescription from a New South Wales GP. So I simply type in the name of the GP if I haven't got a pharmacy that that prescription's being dispensed to, and I can work out that that patient is not here, or that the patient has returned to country, for example, and we know that that person is somewhere else and not with us in the metro area. So I think there is such a wealth of information. It can be useful in lots of different ways, and that includes just the simple transmission of a health summary so that we have an idea of what the person's background is, being able to provide medication for somebody where they need to have that, and particularly things like diabetic medications where you don't want to be sort of randomly choosing what to give them, for example, if they're going into the lockup. It's used, I would certainly use it every day that I'm working in the emergency department, and also on days when I'm working in the homeless team, working to get information. And I think it's become pretty much a reflex from our emergency department medical staff to go into my health record if they have any sort of questions. So I think the uptake has certainly been very high in our emergency department, and if it's not being taken up a lot in other hospital departments, they should try it. There's a lot of good stuff on there. Yeah, I'm a big fan.
That is just such music to my ears. Amanda, thank you for sharing all of that. It's really wonderful to hear. And I'm sure Toby appreciates hearing that full circle as well, with the information that he's been contributing to the system, and that you are picking it up at the other end. A real sort of closing of the loop, which is fantastic. And I'm sure he would be appreciating, if people have been admitted into the hospital, seeing the discharge summaries coming back at the other end as well. Toby and Jill, if I could get you to put your cameras back on, and perhaps Marianne and Simon as well, just while we open up for the panel discussion and check for any questions that have come into the chat pane. Toby, while people are turning their cameras on, I thought you might like to share your story. We haven't really touched extensively on electronic prescribing yet, but that is something that has been really accelerated with the rollout, or because of COVID in particular, allowing that sharing of prescriptions through electronic means rather than paper form, and allowing people to get their scripts without having to come in face to face, so keeping people safe if they're needing to be in isolation or if they're in a lockdown situation. So Toby, if you're happy to share that experience of what happened with you.
And I was able to ring my friendly GP on a Sunday and say I need some more painkillers. Send me an electronic prescription down to the chemist with my wife, no problems. Easy peasy. So I'm keen for us to do it where we work. We primarily dispense. We've got a dispensing clinic, but very often we have people ring from Perth saying, I'm down here, my dosage's run out. Can I get some more? And we've got to print all the scripts out and fax them and post them, and it's a pain. If I could do this and just ping it to their phone, it would be, they could go to any chemist, it would be fantastic. So I'm waiting for it to happen.
And that is a bit dependent on the software vendors and updating their products to enable that to happen. But there is a list of those software products that have got that switched on. And I think quite a number of the main software providers across the country have now connected that to enable the sending of those electronic prescriptions. Simon, next question is for you, and that's really around going back to the digital health tool of Telehealth. I know that PHNs across the country are able to support providers who are keen if they aren't using Telehealth yet, and I guess there's been a bit of a flux of people using phone consultations over video consultations and what PHNs can offer in terms of support.
Absolutely, and obviously speaking from my position as WA digital lead here, so I don't want to talk for every single PHN, but I think we all offer very similar support. We have been able to offer all of our practices, all of our providers across WA with access to the HealthLink video calling platform, which is specifically designed for telehealth, and that's something that's Commonwealth funded and available to all of our practices. So we've been working to link all of our practices up with that. So that's kind of the technical side, and that's actually a pretty simple system to use, and people have found it very user-friendly. But whether they choose to go with HealthLink or a sort of another private provider, we are also able to support our practices with some of those kind of setup questions, some of those softer questions about, well, how do we actually build this into our practice, and how do we ensure our patients are comfortable with this? So we've certainly been there to be able to talk about, well, digital, how do you set up your room? What sort of equipment might you need? What sort of considerations should you take into account if you're going to start offering those solutions to people? And it seems to have gone down pretty well with people. We're very lucky here in WA that we obviously are not particularly hit by COVID, so we've not got too many video consultations going on. People are still able to go and visit their GP quite easily. But we have seen in previous lockdowns that when the worst does happen, when people are sort of a little bit more locked down at home, our GPs have been pretty quickly able to start providing those teleconsultations to a high standard and ensure that continuity of care. So I guess I'd probably just recommend the HealthLink certainly is available, sorry, Health Direct is available to everyone. It's a Commonwealth funded program. So that's nationwide. So if anyone is looking for an option there, that's certainly available to them.
And so Simon, if there's any practitioners on the line tonight who want to be able to do that, what's their best option? Is it to contact their PHN, their local PHN, and ask for support?
I would suggest so, certainly, yeah. Speak to your local PHN. It is possible to go through directly to Health Direct as well, but I think it's always worth having that conversation with your PHN. They may be able to offer that extra support as well in the way that we can. So, yeah.
And Jill, I think this is probably a timely point to bring you back into the discussion in terms of it's obviously transformed how you're providing healthcare for really remote communities. I guess the other thing that you touched on in your presentation was around being able to provide those specialist clinics. Could you expand on that a bit and how that's benefited the community?
So we have funding through Rural Health West to take specialists there, and the specialists come with the general practice team for 2 days from South Australia. 2 of the specialists come from Western Australia, and they're separately funded. But we've not been able to get the South Australian teams in, so we've been doing telehealth with them. So the nurses and I work out who needs to see the specialists, and then we make up a package with all of their results and discharge summaries and things like that. We send those to the specialist, so they've got all of that. And then if the specialist says, you know, what was their renal function like 2 years ago, I've got the notes in front of me, and so I can say that. And I can immediately put all of the new medications into the software. I can order different tests that they want, and we can organise the recalls. So it's We did a renal clinic the other day, and the renal physicians saw 6 people in 2 hours. Like, it was seamless. It was beautiful. So each patient comes with a, you know, for renal patients, they come with a carer who does the interpreting for them, because people speak Pidgin. So the young people come to interpret as well. So it's a pretty full-on clinic.
And I think really just highlights, I guess, the benefit for the community members as well, in terms of not having to make that journey, which in the old days would have been however many thousands of kilometres to get to that specialist appointment, which might then only take 10 minutes.
And so it might be a week to get, you know, to Perth and back. We only have a plane from Jundunjara to Kalgoorlie once a week. So, you know, it might be a week that they're away. And so it's them and their carer all the way to Perth. It's expensive. And as you say, they might be there for 10 minutes, half an hour, and then come back again. But similarly, sometimes, you know, the specialists would go into Jundunjara and everybody had gone off hunting. So they've come all that way and everybody's off hunting, and so there's no patients. But this way, if everybody's off hunting, the specialist can find something else to do.
Certainly makes so much sense in these regional and remote communities, and save so much travel time if it is possible to do those consultations in that way. It makes so much sense in Australia. I guess the next question I was going to throw to Simon again, in terms of joining some of the dots around some of the discussion we've had tonight, and in particular around what Amanda was mentioning about homeless patients. And I know that you guys have done some work through the WA Primary Health Alliance with the street doctor service as well. And have they been putting information into My Health Record and using the system?
We do, and we have done for many years now, since we started supporting My Health Record 3-4 years ago. And funnily enough, as I was listening to Jill and Toby, and actually in fact Amanda, I was struck by some of the similarities when talking about the population that they serve, and some of the stories that I've heard from them around how they utilise My Health Record in particular. So they again have quite a transient population a lot of the time. Sometimes people they will see longer term, sometimes it will be people that sort of pass through their service, and sometimes they'll see them and then not see them again for years, and they'll come back. So they certainly have found that it's a fantastic resource for them in terms of getting information which they might not previously have had access to. So discharge summaries may not have made their way through to them previously, pathology reports, etc. So they've certainly used it for that information gathering for their patients. Apologies if you can hear my children in the background there. It's throwing me a little bit. So certainly for that information gathering, and I think one of the big things, I was speaking with one of the doctors who was talking about how they've also used it to kind of re-link some of their clients in with previous services that they've met with. So similar to the Amanda, you were saying about managing to discover where someone currently was in the country. They've used it as a way to look back and see what services someone has offered when maybe that person would like to go and see a previous clinician that they've seen, but maybe couldn't remember who they were. So using kind of the MBS section, they've managed to track down who that person is and relink them in with someone to who they already had a bit of a trusted relationship with. And then similarly as well, they tend to put more event summaries on than our sort of more mainstream GPs do, because they'll see people as a maybe as a one-off. So similar to Toby, it's not necessarily they would know everything about that person, but they see real value in adding those event summaries to discuss the immediate issue and share that with the other providers that they come into contact with.
Thanks, Simon. That's great. Amanda, just coming back to you, I guess I was wondering what key message you might like to give to any healthcare providers who are working in an Aboriginal medical service or in general practice, in terms of what you find useful and what you get at the other end.
So I think really things like being able to find out who they are, and the practice that they're in, because that's a link to their usual health provider. I think these summaries and up-to-date medication lists really important for us to be able to use. Yeah. And I think it works both ways. So, for example, we can very easily access hospital discharge summaries within the hospital system, but it's much harder, especially out of hours, for us to find information from primary care. But it's very valuable for us, particularly if there's often very little information, for example, and things like just up to date where medications may have been changed, for example, or the doses altered. That can be really valuable for us. It's just safety, and it means that we can continue to work 24/7. With a general practice that's working much less hours, but we can get the benefits of the information that's stored there. Yeah. It's just for us in ED, My Health Record is just an everyday thing now. It's not a special occasion thing to do, it's just every day.
So I'll just skip through some of my previous slides and just point out that we are running virtual classroom sessions. So if there are any of you on the line who don't yet know how to actually upload those documents that we've been talking about tonight, those shared health summaries that then get picked up by Amanda in the ED, you can come along to our virtual classroom sessions and we can demonstrate how you actually go about uploading those documents, and we do them as a live demo in these sessions. So the links are available through the slides that'll be sent out to everyone following the session. We are also running sessions for hospital staff. So if you are in a hospital that isn't using My Health Record yet, you might find that useful, as well as other sessions around data quality, which I'm sure Toby would appreciate as well. So I'm just conscious of the time, and it's been fantastic to hear all these stories. I'll just check the question panel and make sure I haven't missed anyone else's questions being posted. I think I saw a couple flashing up earlier, but while I'm checking that, perhaps I could call on you, Toby, for a final key message to perhaps any healthcare providers that are just starting out on their digital health journey.
Well, I think this is the way of the future. As I say, I grew up from two-way radios and a textbook through telephones, through computers, and this is not the end point. I think this is the beginning of a whole new way of communicating. Too many people drift around the country, leave their medical information scattered all over Australia. They can't remember. Doctors keep moving. The whole system is a mess. And I look forward to a day where we have one medical system, one record system. It might be big brother-ish, but it would provide much better kind of a care. We'll not overlook important things, and we'll not keep repeating things unnecessarily, re-X-raying, re-blood testing. I think it's probably a pie in the sky idea, but it's very useful as it is at the moment. I encourage everybody to use it.
And Marianne, I might throw to you. I think I haven't really brought you into the discussion very much this evening, but any final points that you'd like to share?
I think I would say, don't be put off by what appears at first to be a poor connection. We've had the Norfolk Island come in here, but we have had remote Aboriginal community controlled health services where you barely could get a telephone to work 2 years ago, and COVID has just driven has been the impetus to really fix that up. And so where there was barely a phone call 2 years ago, we now have wonderful multidisciplinary telehealth consultations happening in the far-flung corners of WA. And it's all about, a lot of it's about tweaking, and I just want to reiterate what Simon says, get help, and it's often not the bandwidth, it's all the other little bits and pieces which I don't understand, but when you join all the dots up together, wonderful things happen. Magic happens, as I say.
Thank you, Mary. And I think that's a perfect point to probably segue to wrap up this session. I'm conscious of the time. We have had some comments thanking our speakers for their wonderful and inspiring presentations. Thank you all so much. It's been really fantastic to hear all of your insights and stories. There was also a comment about how can we encourage more clinicians to be putting information into the system, and that's really partly what this is all about tonight. And hopefully we've inspired some of you to now really start utilising the system more and realise the benefits of it as well. So thank you all for joining us. I hope you have found this an inspiring session, and please complete the evaluation that'll pop up on the end of this session after today. And here are some contact details for further information or support if you need it. So thank you everyone for joining, and particularly thanks to our special guests. So wonderful to hear all of your stories and all the wonderful work you've been doing, and keep it up. Good night all.
Good night.
Thank you. Bye.